I'm Cecilia Chisholm and I work in the licensing division of the MHRA, having previously been an oncologist within the NHS. We have a really fascinating and expert selection of panellists, a global selection with a variety of expertise. So what I'll do is I'll let them all introduce themselves briefly, and then we'll move on to questions from myself, and then after 30 minutes, questions from all of you who've participated. I will field to the panellists as appropriate. So Richard, if you could introduce yourself, please. Thank you.
Of course. Good afternoon, everyone. I'm Richard Sullivan. I'm at Guy's and St Thomas's Comprehensive Cancer Centre. I'm the Director of the Institute of Cancer Policy at King's College London. I was the former Clinical Director of Cancer Research UK, and I'm currently chairing a COVID-19 and Cancer Global Task Force on behalf of a number of colleagues from a variety of emerging economies. Thank you.
Thank you, Richard. And we also have Igor joining from the Ukraine, Prof. Bondarenko. Prof, are you able to introduce yourself? Thank you.
Thank you so much. Hello to everybody. Professor Igor Bondarenko from city Dnipro in Ukraine, professor of oncology, head of a unit of oncology and medical radiology. And so the main question and duty which I today want to discuss, this is the issues which appear with the COVID-19 and the work of highly potential sites for performance of clinical trials. I do believe that it is the most important issue, how to keep the sites in good mode during the COVID crisis, and what should we do to make it better and to store our patients and achieve our goals. If shortly, this is my points of view and ideas which I'd like to share. Thank you, everybody. Thank you.
Thank you so much, Igor. And now, Mariam.
Hello, everyone. I'm Mariam Hassan. I'm a physician researcher, and I currently head the clinical research department of a cancer treatment and research facility in Pakistan. Ours is a non-profit charity organization which sees closely 45,000 new cancer patients every year. And of these, nearly 10,000 receive treatment at our hospitals in Lahore and Peshawar, which are the two major cities of Pakistan. So the main focus of my work is mainly clinical trials for both cancer as well as non-cancer illnesses like infectious diseases. But then I'm also involved in research-related capacity building. And ethics of health research in a resource-constrained setting is something that is a personal, it's something that is close to my heart. So I love to be involved in dialogues that discuss these areas. Thank you.
Thank you so much. And also Farah works with Marissa over in Pakistan with Mariam. Farah, do you want to say hello briefly?
Yes. Hello, everyone. It's so nice to be a part of this discussion. And excited to have the panelists and looking forward to the discussion. I'm clinical research administrator at the same institute as Mariam works. And during the COVID-19, we were all through different changes. We were doing certain adaptations in our rules. So, because my prime job is ethics review in my institute, facilitating the review process. So we have done adaptations in that process. That is something in which I was directly involved. And then, yes, we have witnessed how the changes and the adaptations and how the COVID has disrupted the cancer. So I'm looking forward to a great discussion. Thank you.
And finally, thank you, Farah. Thank you. And Alyssa in America.
Yes. Good morning, everybody from San Francisco. My name is Alyssa Pritchett. I work at the World Economic Forum, which is a 50-year-old nonprofit organization committed to improving the state of the world through creating public-private collaborations. My role at the forum has been on the platform for shaping the future of health and healthcare, focused mostly on precision medicine and also managing the Global Future Council on Biotechnology. Prior to the forum, I worked in the pharmaceutical industry.
Thank you. So to kick off, I was going to start with quite a broad question, maybe start with Richard. How has COVID affected the ongoing oncology clinical studies? A massive topic, but if you could start on that, please.
No, my pleasure. So, I mean, I think broadly speaking, it's created enormous uncertainty. I mean, the reality has been across the globe. Many countries have seen their trials and clinical studies either suspended or completely shut altogether. And we've seen this because essentially, right at the beginning of the pandemic, it was incredibly uncertain about which particular interventions, particularly those that were immunosuppressive, were going to lead to increased risk for our cancer patients. And it was felt that in light of this great uncertainty about the risk factors, the best approach was a precautionary principle. In many places, we are starting to see some of those clinical studies restarting again. Some of the critical studies that simply couldn't be stopped, for example, phase 1 studies, have continued, obviously with greater oversight during the pandemic. But broadly speaking, we've seen a shutdown. I think it's going to be interesting, and I'll be interested in other people's comments on that. I think for many of us, the question is going to really be now, which trials can we actually restart again? How do we restart them in light of still a great deal of uncertainty in terms of the ability to redeploy staff back to these clinical studies? And also, I think looking into the future more broadly, and we might pick up this a bit later, is we are going to see dramatic downturns, I think, in the general public support in R&D. We've already seen CR UK, Cancer Research UK, in the UK, cut 20% of its budgets across the piece here. So the clinical studies in the future, I think, were also under great uncertainty.
And following on from that, Igor, what changes have you had to do in the Ukraine to try and keep certain clinical trials running or to keep patients and your staff safe during this time?
Thank you so much. Thank you. You know, we are 18 years at all. Today is 12th of August. Our first patient was randomized in 2002, 18 years ago. We randomized the first patients, and since that, 4,200 patients were treated in clinical trials in 365 trials at all. I mean that we were strongly involved into this activity. And in March of this year, when we faced with COVID, we had totally 382 patients who were treated in 29 different trials on site. That's why the main challenge and issue which I faced with was how to get patients safe from this event, from this infection. You know, we every day faced with the situation when we have every day 70, 80 patients on site and near 100 staff employers. Totally huge amount of people who were get together in one place. So it was very high opportunities and the risk to create the flame of infection inside. You know, that's why you know, I just remember it was on March 10, we stopped the site for 2 days, immediately stopped all activities. Prior of the, at national level, 2 days before at national level, the shutdown was announced. So they do rebuild all activities which we have on site with idea to ensure safety of all participants and employers. So finally, the results of these actions were that 99% of procedures which we plan to perform within these last 3 months were successfully done. We listened patients within 3 months, 18% of patients. The enrollment level was 3 times lower than it was usually. But nevertheless, at this time, we are treated 300 115 patients in 23 open trials. So the challenge which we have which we face to ensure a safe mode of all process, I believe, and so to show the reliability to all our sponsors and all participants and the patients for the first time. And the second thing which I believe is important at particular this time, because we are 3-4 months behind the beginning of this infection. Now we have to create opportunities to rebuild ourselves, to increase in our activities. And so within the last 2 months, first of all, we stop our the go down process. We just now begin a slightly move forward and increase our figures. That's why this is the main challenge, and I believe we act this in this situation. First of all, to separate all patients and to prevent huge number, simultaneously number of participants, so to improve the site management process, site management system, implement automatic clinical trial site management system, remote monitoring, remote staff work, and many other things. I believe if I will find the request from the auditor, it may be discussed more strongly, maybe, so I'm ready for that. But finally, I believe that now we are in time when the companies propose more and more new trials, because for the 3 months from March, April, and May, we didn't receive any propositions for the new trials from industry. Now we are discussing 22 contracts for further trials. I believe we are now in time when we have reopen our industry, our business, and make it possible to achieve very high goals. Thank you so much for this, for your attention. Thank you.
Thank you. That's a really fascinating insight, and I think we'll touch later on quite a few of the things that you've mentioned, particularly the technology and the adaptations that we probably have to take forward in future trials. Moving to Pakistan, Mariam, what changes have you seen over there, and how have you decided perhaps which trials to continue, which to stop? Have you had to change treatments, and what sorts of modifications have you had to make over there to your clinical trials?
Thank you. I'll make a couple of points, and they might appear a bit disjointed, but there's a method to the madness. So I'm a big believer in context. So any implementation or any changes that you make, especially when faced with a pandemic that affects the whole world, they are only as good as the context within which they are being implemented. So the context for countries like Pakistan is that we already struggle with cancer facilities, and research per se is not a priority when you have to struggle with provision of essential care services. So research already struggles with, with being recognized as an essential need, although there is, because without data, there cannot be appropriate planning in countries such as Pakistan. So, so when this pandemic started, there was a lot of fear and panic, and because most of the models for control and the changes that were being implemented across the world, they were coming from high-income countries that could afford full lockdowns over extended periods of time. So most of the lower middle income countries like Pakistan, their initial knee-jerk reaction was also to adopt those same things. But I think many of us realize that this is probably not the answer for us, because there are socioeconomic realities that just make it impossible. And I wouldn't say that these socioeconomic realities are the same across the country. There's a huge gap between those who have everything and those who don't. So even within the same country, there were people who had the means to shut themselves off from the rest of the world. But then the 25% of our population, which are daily wagers, could not do so. And then, this is the same population, the treatment naive population, that is also eligible for many of the clinical trials that we do. So, so there was a lot of resource allocation. Maybe we can discuss it in the later part of our discussion, that we have had to do for our cancer treatment also. But then there was a very rapid realigning of our current resources dedicated to research, because our first question was that is research even a priority for us right now? Because you see, Shaukat Khanum, the hospital that I work in, is a non-profit organization, as I shared earlier, but it's also a state-of-the-art organization. So so it was, and we are run by donations from the people of Pakistan largely. So our organization felt a need to contribute to the people who contribute to our cause. And we could not become a general quarantine hospital. Our forte was provision of critical care services, which is a very scarce resource in Pakistan. So in Pakistan, we have about 4,000 ventilators for a population of 220 million. So we thought that this is the best support that we can provide to this cause of COVID-19 management. So we realigned a fraction of our sources to converting our wards into these ventilated beds, on an urgent basis. The other thing which directly impacted research was that there was, the biggest challenge for low middle income countries is to have state-of-the-art labs that can provide good, reliable diagnostics. This was a huge challenge across the world during this pandemic. So we had a molecular pathology lab, which very few tertiary care hospitals in Pakistan have. So our lab became one of the three, reference labs in Pakistan that were initially, validating the kits and performing COVID-19 diagnostics. But then we needed more space. So the earliest realignment of research resources to provision of something else was that our basic sciences research lab became our diagnostic lab. And the research associates were trained overnight to become a part of the molecular pathology team and aid them in diagnostics to run thousands of tests that were coming our way at the start of the pandemic peak in Pakistan. This meant that the basic sciences research lab activities had to be certainly halted. And this also meant that we are a sister department, the clinical research office, which was enrolling patients for those studies, had to then decide something else. And then similarly, we were rescheduling elective surgeries. We were pushing them forward, and we tried to complete as many surgeries as possible within March. And we pushed elective surgeries forward. But then this meant that many newly diagnosed cancer patients were told that your surgeries will be done later. These were also patients who were part of many of our cross-sectional studies. And here I would also like to highlight the human impact, because it was very demoralizing for my team to talk to these people and these patients in the early part of the pandemic peak, because they were seeing patients approaching them for some research studies who were truly in shock over their recent diagnosis of cancer, and then being told that we cannot offer you the optimal surgery or treatment right now. Because many of those patients who needed upfront surgery were told to either go to another center which was still performing those surgeries, or maybe use some oral chemotherapy, which was certainly not the gold standard for management of that particular disease. So discussing research with that patient, when you can clearly see that there was a dilemma there. This was for a short while, and we started performing surgeries as soon as we could manage safely for both the patients and our staff. But that short while was, I think, very difficult and challenging period for both us as healthcare providers and researchers, and of course for our patients, who were the major stakeholders. This impacted them the most. But then all was not gloomy, I would say, because we learned a lot as well. I'm sure my colleague is going to share how we adapted and developed our robust and a quick ethics review process that offered speedy but robust reviews of research, with its challenges, of course. But we also saw that this led to a lot of communication and coordination between institutes who were previously not collaborating as much within the country. So it seems that if nothing else, we have achieved a collaborative hub of clinical trial sites that are able to work together. And I think for us, this has been a huge achievement. Because for countries like us, even that becomes a challenge at times, establishing links within the country. And then, another great experience has been using telemedicine as an alternative, which I think Dr. Igor has also pointed out, and using remote technologies. I think the future is going to be central statistical monitoring and remote monitoring. And I think this will bring down costs, and this will change the future of even non-COVID research. So I think there have been challenges, there have been difficulties, but we have also had some really great lessons, because unlike March, we were just looking into a crystal ball, we now have actual experiences that can guide us. So I think I'll stop here, and maybe we can continue this during the discussion.
Thank you so much. That's absolutely fascinating to hear how you've started to overcome the challenges. And leading from what you said, I wonder, Alyssa, have you got a bit more insight possibly into the innovations that could be implemented in the future, what help they might provide, and also, of course, any risks associated with this and difficulties that we might need to try and overcome? Thank you.
Yeah, certainly. And I also want to comment on what some of the has already been said. There are 12,000 active clinical trials in just the oncology space, and to run a phase 3 clinical trial is $20 million. So when we think in that context, questions I have, and I'd be curious around responses, what will be restarted quickly, what will be delayed, what will not have the funding to go forward in terms of future clinical trials, current clinical trials in oncology. From the ongoing trials, what data, since we've now seen data gaps, will be acceptable, particularly to regulatory agencies, and will we see some kind of forced move toward flexibility, adaption of clinical trial approaches? I think some of this may hit in accelerated approvals in areas of significant need. But I'm very curious to see what the data gaps will do to drive advancements in clinical trials. From a technology perspective, so it's very, very interesting. There is a growing area that some of you may have heard of related to the Internet of Things, called the Internet of Bodies. And this is really about wearables, ingestibles, implantables that record human health data, human activity. And these have started to be incorporated into clinical trials. I think we'll see potentially the increase of that based on some of the experiences that have now been had through COVID. It's not super straightforward, There are issues around standards. So how are these technologies collecting data? Is there minimal standards around that? So that information coming from these IOB devices can be compared with each other. There are certainly questions about privacy and how that data is kept and protected. Questions around governance. The kind of interesting, well, one of the interesting parts of this is there's a real convergence I think we're seeing between these devices that are used in the medical space, which is certainly highly regulated and protected, and those devices that are in the consumer wearable space. And I think these areas are going to start to merge. And for now, there are different regulatory bodies that tend to oversee these types of technologies and different levels of regulation around them. And the need for expanded or modified policies related to, again, how that data is treated. I believe GDPR already addresses human biometric data, but HIPAA at this point does not. So I think we're getting into very, very interesting territory in the technology space related to wearables and application of those to collecting health information.
Thank you. I think, as you say, it is going to be obviously a massive area moving forward. In terms of the trials that are ongoing, I was wondering, Richard, whether you've got a bit more information on how the ongoing studies, which ones carried on, how they were changed, what sort of different assessments were done, whether different treatments administered, and a bit more information around what actual changes to the ongoing studies had to be implemented on a fairly quick decisions had to be made.
It's fair to say it's been incredibly heterogeneous. You know, talking to my colleagues in various countries and certainly across the UK, those trials, you know, that kept going, that were able to keep going, were done so on a very distinct centre-by-centre risk assessment. So particularly being, for instance, early phase clinical trials that simply couldn't be shut down because these were the only route for any potential treatment for the patients. In other areas, trials which continued in certain centres were shut in other centres because staff were either furloughed or moved elsewhere, or because the overall risk in that particular centre for COVID-19 was considered to be too high. So what you saw is within one single multi-centre trial is some centres continuing and other centres shutting down. The other issue I think is going to be looking forward is we've seen quite dramatic changes to what's been the standard of care for many of our patients. Moving to hyperfractionated radiotherapy regimens, additional new access to particular chemotherapy drugs, for instance, that we have not used before, enzalutamide, for example, in hormone-sensitive prostate cancer. And so the changes, I think it talks to the previous speaker's point about the changes in standard of care and how we're going to adapt as we restart some of those trials again are going to be very complicated. And the other thing to say is, you know, I think absolutely there are certain practices, I think, within clinical trials we'll want to continue. We certainly don't need to bring our patients in as much as we have been doing in the past. A lot more central data verification, excellent idea. But the reality is, and I keep saying this to people, is we can't have our cake and eat it. If we want to do complex, multi-center, multi-arm clinical trials with cancer patients and do biological add-on studies with increasingly complicated regimens, different approaches, neoadjuvant, I mean, zero window opportunity studies, we have to have them in a setting where we are able to take multiple biopsies, where we're able to image them, where we're able to keep a very tight eye on them. And I have to say, I still struggle enormously with this tension between the safety and security of patients within COVID-19, but making sure that these patients still have access to clinical trials going forward into the future. And to let a bit on, we're already hearing worrying discussions about the fact of, you know, age and comorbidities being such a risk factor for SARS-CoV-2. People saying, well, we're going to have to tighten up our inclusion and exclusion criteria within clinical trials. Now, that's a retrograde step. We've been trying to open up our clinical trials to encompass the biggest patient populations. This is done for Olympic, level patients in Olympic centres by Olympic doctors, and everybody else is excluded because of some notional idea of risk. So I'm not trying to downplay the risk of COVID-19 here. What I'm maybe trying to say here is I think we've got a lot more complexity and heterogeneity and honesty we're going to have with patients, regulatory bodies, and indeed sponsors to get through this pandemic and get all those trials going again, and indeed ensure that we start up new trials as well. Because at the moment there are no new trials in development. People have really shut down on the startup and design. And I'll stop there. Thank you.
Thank you. Yes, there is a danger if trials are designed around coronavirus, then their applicability as we move on to the future, and actually they're not generalizable in the post-COVID era. They've been too specifically designed for now. Igor, do you feel there's been a lot of missing data? Do you think the trials that are running are still able to provide useful data, or do you think that is going to be an issue moving forward, that some of the trials running currently won't be able to reach the outcomes that they're trying to assess?
Okay. Thank you so much. Thank you so much for this question, because I was wondering many times with the same things during these previous months. I asked my colleagues, the monitors, how things are going on in other sites, in other countries. So about missing the data, about non-completeness of the medical records and so on. How is it there? So, and I receive different information about that. But personally, for myself, it was not a problem to really to follow all let's say GCP and all other requirements for the trials. Why? Because I'd like to show it. So here this is my cell phone, and this is our program. We were talking about the opportunity how to better manage this site, and this is our invention, our clinical trial site management system, which is located in my cell phone, in every other device, and it really assists to prevent non-missing any data at all. What I think, we may be willing to work effectively. We may have this maybe desire to achieve our goals. The main question is, how is it possible? How we must be trained and how we must be ready for that. It was the great challenge for me how to ensure all this process. And when I showed you this system, we invented it within the last 5 years, and we tested using it in clinical trials. It was like our answer for in trials. We tested the medication, the medical drugs. I tested at the same time the management principles and site management principles, and with the idea to answer for your question, to ensure very high quality. So if shortly, how it may work and how it may achieve goals. First of all, such systems have to plan all kinds of activities. The second step, to control performance of all activities and procedures automatically, scanning QR code and automatically receive reports about performance of procedures. After that, such kind of system may generate high quality medical records according to this scheduled procedures, and we will receive medical records and events which all must be done because they are pre-planned and controlled. So after that, what is the next steps for such systems? I believe the next step is to give quickly automatic data to data managers to ensure the quick transferring of data from medical records to the data management to electronic to ECRF, to electronic CRF. Such system might assist in that. The next idea, how to calculate all what we have done and to prepare financial invoices, which will really reflect all process what we done to calculate the correct payment system and in time payment process. So, and what after that? I believe it's very important, especially in this time, to create conditions for remote monitoring, because during this time, within 3 months, we didn't have at least on-site monitoring. We have only monitoring remotely. And how it make it possible? Our system answered for that questions. Our monitors have chance to check everything remotely. And now, within the last months, when they have the chance to be on site, to travel to our city, because it was closed for some time. So we find out that remote monitoring show very good results. And now when they compare the data in our on-site documents and what they had checked remotely, everything is in complete coincidence. This is the very important thing. I believe it may decrease the cost of clinical trials, dramatically decrease, if the monitoring at high level will be automatic and remote. And the final step, we just now invented, create the system which may ensure automatic transfer of all data which was captured on site level automatically to electronic CRFs. So we tested these ideas, we tested these thoughts with our IT specialists, and we find out that it works. It may be working. And now we are only trying to find somebody else worldwide. We didn't find them, honestly speaking, in Ukraine. We are trying to reach colleagues, friends, the people who think at the same mode, how to make clinical trials at much better level, how to decrease the cost of the trials, increase the safety and the reliability of data, increase data transfer process immediately from site to electronic CRF, let's say, automatic transfer of data from our from these systems which I had shown for you to the electronic CRFs and so on. You know, excuse me, just now it is in brief. I just reflected our thoughts and ideas, but I'd like to say, and I want to say with proud, that really we reached these goals during this time, because 99% of planned procedures, as I said, were performed on site. In figures, it sounds like 1,000 visit of patient to site, 1,000 per month, 400 courses of chemotherapy, 155 monthly assessment by computer tomography results of chemotherapy. I mean, it is rather powerful volume of work. It is not small site. It is the site where, for example, I personally, for myself, is able to manage with 65 simultaneously different trials. 35 with them are open, other with completed enrollment, but still continuous observation for the patients. 15 are in follow-up period, but due to this electronic management system, I am able to hold in my head everything what is related for that. That's why I just have an appeal for everybody who is listening to me. So my emails are open, and the meeting organizers, or even you might take a look. If it is here, I don't know why. No.
Thank you, Igor. That's brilliant.
Oncology, DSMA, DPU Ukraine. I believe that we have to change philosophy and strategy of performance of clinical trials. The site must be much more powerful, effective, and decrease the size of the studies and increase the number of studies we simultaneously may perform. That's why I will be happy if somebody will think the same way and will be ready to cooperate with us. I believe that such kind of system should be implemented, and the paper documents should be excluded from the mode of our daily activity. We must change philosophy of that using electronic systems. I'm looking for the partners and friends. Thank you for your attention. Thank you.
Thank you so much. Thank you for that fascinating insight. I was wondering, Farah, do you have, adding on from the changes we've heard about, what other changes have you had to implement over in Pakistan to try and keep the trials running and modify the way that you're doing things to try and help patients?
Thank you. Thank you so much. So first I would like to make a comment that the discussion has been, it's a great learning to be a part of this discussion and hearing from others how they have responded and what adaptations they have done. So in Pakistan, Mariam has already shared the context and the situation and few of the adaptations that we have done in Pakistan. So yes, when COVID reached Pakistan, it was already a few months that it has already affected other areas, and we were rather expecting or predicting the wave would come to Pakistan by that time. So we have some time to prepare, but at the same time, when it actually hit us, it was the time when we have done most of the adaptations, and by the time right now we have learned a lot. As I would agree with Igor that many adaptations were done, and we have learned so many new lessons or smart ways of doing things. So clinical trials were affected. It is not, there is no doubt that there were many factors. The resources were allocated. The capacity to do clinical trials was affected because of many reasons. Lockdown and the fear of having the infection, it changed the health-seeking behavior of patients. So there were inevitable changes and deviations. So either the trials were stopped because the capacity to run those trials, to continue with those trials, was limited. The trials where this decision was not made per se, the COVID has a negative effect in any ways. We are having problems in recruitment of new patients during this time, and of course because of the reason, there are many things have changed, and especially the health-seeking behavior of the patients were changed. So we were all learning, and we switched to telemedicine, and then we did few adaptations. So I think by now we have learned how to use technology, and even this can be more efficient, or this can be more, it can be more accurate, it can be more convenient. So so these were all the lessons that we have learned, and it has helped us a lot. And I think this is the time to understand and learn how we would react or respond if any such happening, or if any such future pandemic hits the world again, as well as the normal has changed as well. So we have learned many useful things that we can continue during the normal periods, known pandemic periods. Use of technology, use of virtual meetings, use of telemedicine, or virtual visits by the patients. So these were all learning. I'm primarily involved in ethics review, so we have done adaptations in ethics review. There were a lot of pressures, there were a lot of uncertainties, but we did adaptations. One of these involved moving from paper to electronic formats. So we are still struggling. We need to optimize and upgrade, but there is a new direction to go. And there was a surge in COVID-related research, and we have also learned that we can act in a more accelerated way. The reviews can work in a more accelerated way. Regulatory bodies, ethics, and ethical bodies and the sites can coordinate, and they can work in a more synchronized way, which is more efficient. So maybe we do not need to stop what we have, what good practices that we have learned or achieved during this COVID period. In non-COVID or non-pandemic, we can still continue with the lessons learned during the COVID. So, and yes, prepare for the next emergency. We can hope, we can prepare that we would be better prepared for any future untoward happening. So this is my feeling, this is my perspective. Thank you.
Thank you so much. Again, you touched on the importance of innovation moving forward. I was wondering, we've had a question from the audience to Alyssa. What you mentioned, the importance of standards if we're going to optimally exploit the possibilities, these innovation possibilities. What sort of standards were you referring to, and which are the most urgently needed of these?
This is a great question, and I'm happy to follow up. I have colleagues who are more experts in the IoT space, but I think I would look at it from a couple different areas. First, just basic technology standards across all of the wearables that might be used in the medical space. Right now, that again, these devices will collect information differently, and that can cause variations in the data that is delivered back to the physician. Also, I think of this from a governance perspective. So how is this data being kept private? What are patients knowingly consenting to regarding the type of data that's being collected from them, how long that data will be accessible, what other data it might be combined with, and how it will be used in the future. These are kind of general areas around the use of data that are ones that still need to be addressed across many spaces related to healthcare. And then also the collection and access related to that data. So as it is stored by an institution, what security is put into place to make sure that data is really well protected, and if that data is then shared to another institution. So if we're talking about kind of data coming in from multiple different remote areas to one centralized location, how is that data really then being truly secured as it is traveling? If it is then shared with yet another institution, is that institution following the same governance models, the same level of responsibility, accountability that the original institution is, and who is setting those standards? These are all really, really important questions to think through, and for organizations to develop a practice around as they start to share data. So I hope that helps answer your question, John. Please drop me a note in the chat if you'd like to hear more.
Thank you.
One more thing I was going to add. So this is a little bit of a different perspective, but around the use of wearables, the adoption of technologies, I think we're still, it feels like eons since the COVID pandemic started, but it's only been months, and I think we're still very much in a learning and coping phase, and trying to figure out what are the key questions we need to answer, what learnings can we gather, and how do we apply those. And when it then starts to move past the pandemic, or we find ourselves in between waves, are people going to have an incentive to go back to their original behavior, or are we going to start to plan for the future of a second wave or another pandemic? And with that comes the issues of how can these technologies be deployed in a way that it is sustainable? So that cost money. Our governments and businesses and other organizations that are certainly financially strapped right now, are they going to be able to fund the development of these data infrastructures, the new or expanded regulatory body work that needs to review and approve certain things? How is this information and the use of it going to be de-risked? You certainly want to de-risk as much as possible in clinical trials, again, because they're very expensive. So if you start to expose new ways of collecting and looking at data, that needs to be done very, very thoughtfully and carefully. And again, how is everybody kind of across the value chain here going to be incentivized to start to address not only the standards, the governance needs, but the use of that technology?
Thank you. You touched there on something which I think a lot of people are thinking about, which is the possibility of a second wave. So just maybe Richard and then on to Mariam. How do you think this risk in the back of everyone's mind is influencing how clinical trials are being performed at the moment, and how clinical trials will be planned and performed in the next few months moving forward, other than the technologies we've heard of? Are there other, do you think this will influence the sort of trials that get started, and what sort of outcomes we'll be looking at?
Yeah, I think it's, you know, the behavior patterns have changed dramatically, both for our patients and also for the clinical community as well. I mean, we talk about this notion of second wave. The reality here, this virus is here, it's here to stay. It will keep sweeping backwards and forwards inside our populations until either an effective vaccine is rolled out or we achieve some form of herd immunity. And that's even more complicated because we now know, for example, the antibody tests don't reflect true underlying immunity. We know there's cell-based and also innate immunity within the population. But what this all adds to is uncertainty. And if you look at, for instance, my clinical community colleagues, let's say in surgery, there's a far lower risk threshold there. You know, a lot of surgery now is being put off. High risk operations that would have been undertaken before now are being pushed out. And so when you look at, for instance, clinical studies, perhaps looking at a new adjuvant therapy to downstage for surgical procedures, we're just not seeing a lot of these either coming forward, or the ones that have been suspended, people are now questioning whether they should restart them at all. Now, that's just the behavior of the clinical community and the clinical leaders here within these particular areas. Then you have sort of maybe more bullish, I would say, people who are more used to managing risk. Colleagues of mine in hemato-oncology, I think, are much better at managing, you know, overall risk to patients and making those trade-off decisions with the patients. But then, of course, one has to ask the question then, what about the patients coming forward and agreeing to be participants in the trials in the first place? And that I think is a complete unknown, and it will depend on a lot of factors. The way the media is portraying cases at the moment is frankly nonsense. I mean, what counts is hospitalizations and number of people you have in ITU. It's not just the general background noise of cases here. So I think we're going to have to see a shift in the way that the fear, if you like, and the public messaging around this virus is put out there to change behaviors overall. And that's going to require, I think, a lot of community leadership and an awful lot of what I would consider to be clinical leadership as well, to get things restarted, get new trials planned, and to get those trials started in the first place. But again, it's incredibly dependent. It's dependent on the centres agreeing to allow those trials to happen. It's dependent on, I think, a lot of IRBs and RECs saying that a new trial that's being created is safe enough to start within a period when COVID-19 still is a background disease and the virus still remains, in inverted commas, a threat. So I think all of what I'm saying here is there's still a tremendous amount of uncertainty going forward. I think a lot of people will try and restart trials which were suspended, particularly those important trials which are quite far through at the moment. I think quite a few trials are going to fall off the edge. They'll never get restarted. But I think the big concern is the de novo trials, which have been in design phase, which people would like to start, and are now kicking the can down the road. And they should have been starting this year. They won't start until Q1, Q2 next year. And again, as I said before, it's going to be incredibly dependent on the whole business of the vaccine and the way that we perceive the risk in these individual clinical communities amongst our patients.
Absolutely, as you say, it's patients' fear of hospitals aside from their underlying disease, which is a massive factor. So, Mariam, while you're still here, how do you see this issue where you are? How do you feel that patients want to interact with your health service, and how do you anticipate it'll look maybe next year in terms of how clinical trials will be running and run, and how you'll be able to recruit patients?
Thank you. I think what this pandemic has really highlighted is our moral responsibility to have a really robust dialogue on two very crucial issues, because we have seen the good, bad, and the ugly of research in these last 6 months. We have, every deficiency in the research system and research process, including the ethics and regulatory review process, has been even more gravely highlighted in these past few months. So I think while we should certainly adopt technology, it has to be done in conjunction with a dialogue on two critical issues which have emerged during this pandemic. And only then do we have any right to go to our patients and ask them to offer themselves up for the risk of research. Because while research is a right, it's greatly altruistic on part of a cancer patient to also offer themselves for clinical trials, because it's research. It's not offering them a benefit per se. It's helping us answer a question. So we have to fix the research process. And for that, the dialogue that is needed is for two core things. One is the issue of research exceptionalism that we saw during this pandemic, which was justified in the name of having speedy answers. And then we also saw a fallout of those exceptionalism that was made because there were retractions for hastily made publications and major issues with data. So this dialogue needs to be in place, not just for future peaks and future pandemics, but for the whole research enterprise. The second dialogue that is really important, especially for LMICs, but I think for everywhere, is the centralization of, and this was something that Dr. Farah and I were discussing just today, the centralization of the ethics review process. Because it takes so much time for us to be through with the approvals process. Whereas having us, and this is a model that Europe has been using for a while now. This is already in place in Netherlands. They have a central ethics review system, and institutions essentially assess feasibility and logistics and their scientific interest. I think that actually has the potential to revolutionize, research robustness even more than any technology can. And by centralization, I do not mean that we do not develop institutional IRBs or we do not, create standards for them. But in a pandemic, there should be there should be a process in place that provides robust and speedy review, but that does not compromise the real assessment that is needed at that time, which brings me to my second and last point, which is that the biggest challenge in while doing research or clinical trials in a public health emergency is negotiating the emerging evidence and its uncertainty. And it has been so problematic. Trials, I will refer to the WHO Solidarity trial when it was when countries started taking it up. The risk-benefit ratio, the clinical equipoise surrounding the treatment arms, and the clinical uncertainty around treatment options was completely different than it is today. And we have seen that how helpful adaptive trial designs can be. And this again is going to be the future for not just COVID research, but also for research into other aspects of global health, including cancer trials. But for that, we will need to do capacity building, especially in LMICs, because if we don't have statistical capacity building, we cannot even think of doing adaptive trials. And the very final point is the importance of large collaborative platform trials. Because I think, and this is something that was pointed out earlier as well, we need to do complex oncology trials. But there's a better way to do these, and the better way is to do these collaboratively.
Thank you. Yes, that's very, very important, that hopefully moving forward we can implement some changes. We don't have to stick with the status quo, and actually we can, from what we've learned, move forward and hopefully conduct clinical trials in a better way for patients. Well, thank you very much, everyone. I think it's about 5 o'clock. I think we have a tea party now, but I'm not quite sure what that involves. So maybe if anyone from the faculty is around just to say how that runs, that would be brilliant.
So yeah, thank you for that, and thank you to everyone who's participated. Sorry,
yes,
I'm still
you
sweating
so
here.
much.
And so basically it's an open house now, so people can post their questions, and we've got some questions in the chat box, Celia, if you can see them.
Oh, okay.
We'll just continue seeing them, and I've been sending them some of them to you. So if you want to take, so if you want to take them in turn, then we can take the questions. One of the first ones was from, let me just see if I can find it. Craig. So Craig's asked a really good question. Could you give us a little more detail about how various research units have reduced the risk of cancer patients acquiring COVID-19? So who wants to take that one? Any volunteers?
Sorry, just couldn't repeat that one again, Marcy, could you?
Yeah, so could you give us a little more detail about how various research units have reduced the risk of cancer patients acquiring COVID-19?
We should just kick off with some comments across the UK. I think, well, first things is ruthless and rigorous testing, both of staff going in and also of patients coming in, and having some very standard biosecurity countermeasures in place. You can't call anything COVID-free, as we know here, because of the asymptomatic shedding and because of the difficulty in latency periods. But what you can do is reduce the potential for being picked up. And actually, one of the things we found as well is the ruthless needs. I mean, it sounds strange to say, it's just to keep your hospitals clean. I mean, there is a reality here about, keeping your hands clean, cleaning surfaces, cleaning equipment. I mean, we've known about this for years, actually, but let's be honest, this is probably the first time I've seen the hospitals being properly cleaned for an awful long time. So this is an important that we're affecting the right sorts of sort of reasonable social distancing here, and allowing those patients then to come back in and be seen. But it does reduce the throughput. I'll be absolutely blunt with you. We cannot see, for the clinical research studies, the numbers of patients we used to be able to see in any given day. And so for existing trials, of course, it just means everything takes much, much longer. And for any new ones coming in, it's the numbers of patients we can go through in terms of potentially getting people to consent to a particular study. But most places now have good protocols in place. There are variations on those protocols, but by and large, the ones I've seen from across Europe satisfy most of the needs around the sort of biosecurity area that you need for a safe space. As I said, for not COVID-free, but COVID-light.
Thank you.
Thank you.
And add a little bit to Richardson, okay? I'd like to add a little bit for that, okay?
Yeah.
Brilliant.
Yes.
Yeah, thank you so much. Thank you, Richard. And I'd like to add that some unusual things which we have implemented into practice may be effective. In our case, as I previously said, we separated all the patients for different groups. It was one step. So they exclude all public transportation of the patient, then they are moving to the hospital at all, only taxi cabs and so on, which are paid with the companies. The good idea is the important, small but important things, I believe so. Well, of course, all all procedures which must be at high level at hospitals, nothing to discuss with that. So what else? We had recorded some small videos, like educative videos for the patients, and showed this video when they are on site. Do you hear me well? It's okay? Yes, yeah. Well, thank you so much. Okay, thank you. So we show these small educative videos, how they must, what should they do to exclude the risk of bringing COVID to the site and to all of them. So one of the actions is, it's obligatory for physicians, for example, today call for the patients which will attend us tomorrow to check his, by phone, to check his condition and explain that in case of any symptoms of maybe COVID, the patient should stay home, not bring it to the hospital, because if you have a lot of patients, it will be very, very poor results. So another things, the monitors to site coming every day, 5-6 different monitors. We are also in contact with them and try to defend them with all opportunities which are obvious, the social distance and so on, because it's also very important. But the personal responsibility of staff and the personal responsibility of our patients, I believe it is very important. They will take care about themselves, and they will take care about other people who are on site and who are nearby with them. It may really be good results. So I just pay special attention for that. Thank you, colleagues.
Thank you. Can we we'd like to invite Professor Zulfikar, if he can discuss his view as a member of WHO working group and his expertise in pediatrics. Professor Zulfikar is originally from Pakistan and works now at the University of Toronto. So Professor Zulfikar, would you be able to discuss your view as a member of the WHO working group? We can take you off mute. Will, can we take him off mute? There, I can't do it. Will, can we take Zulfikar off mute, please?
Yeah, or he can do it himself.
Oh, sorry. Yeah. Professor Zulfikar, would you like to just give your perspective? Or not? Okay, no, obviously not. So, back to you, Cecilia, sorry. There's a question from Banerjee to everyone about participation in clinical trials being beneficial to oncology patients. So yes. You want to pick that up?
He's just mentioned that obviously participation in trials can very much be beneficial in terms of the potential for benefits, the potential for receiving new treatments, and the potential that you're actually being closely monitored in terms of safety, safety signals being picked up. I think, yeah, we've not had any more questions from the audience particularly, have we? I don't think. There's one here that's quite interesting that I'll pose, which is, do you think in the clinical community we have more to do to try and encourage people in this era to participate in trials, given the fear that patients have? How much do you think we should be doing around this to try and positively encourage people, or is that not something that we see ourselves doing? Does anyone want to pick that up?
I can't comment on encouraging people, but I think, you know, some of the issues that are facing clinical trials now are not necessarily new to the COVID era. The issue of being able to access clinical trials, diversity in clinical trials, inclusion in clinical trials. And I think some of what's been talked about on the panel already points to questions of how can health system design be adjusted to increase those opportunities, such as, you know, as was discussed, telemedicine. Potentially there's opportunities to set up more remote labs, which enable patients to not have to travel, but also puts clinical trials out beyond just academic research centers. And in the US, I think there has been a movement during at least the COVID time to try to direct patients to go to more community-based hospitals. I think that, you know, of course, it requires more certification, more funding, but these are potential ways to engage a wider diversity of patients in clinical trials. So not exactly the answer to your question, but I think it's important to note. And I agree with the statement before, you know, just going back to the patient perspective, for a number of patients, clinical trials are a source of hope and a way to access potential life-saving treatments when they have not been able to do so otherwise. And the stress, the anxiety, the fear that they're dealing with right now, and their families are dealing with right now, to make the difficult choice of, do they try to find a trial, do they continue going to a trial, or do they stay at home and try to avoid catching COVID when they're immunocompromised, is a very, very mentally and emotionally devastating decision. So I do think that's exceptionally important to always keep in mind, and how can what we are all learning from the COVID period also lead to ways to reduce that kind of stress and anxiety for patients is really critical.
Thank you. Yes, trying to positively engage the patients is a really such an important issue. I was wondering, there's a question here. Is there any data on how patients in clinical trials are affected with COVID-19 compared to the general incidence in the sort of general hospital setting? Does anyone have a feeling for, cancer patients are more at risk, but does anyone have a feeling for whether in clinical trials it's more than in the general population?
I think right now the only thing that we know is that cancer patients who are on active treatment and who catch COVID-19 and who have the other risk factors of age above 65 or other comorbids certainly have a higher mortality. But other than that, because a lot of cancer research was halted or at least realigned during the peak COVID-19 times, I don't think that so far there has been any, greater mortality that has been observed. This is what I think.
Thank you. That's good to hear. There's a question here to Dr. Farah from someone in the audience, which is, do you think you will change your cancer research in Pakistan following COVID? Any other specific changes that you envisage? And also, I'd be interested to know from you as well, what proportion of your trials are academic versus industry trials, and whether there are many industry trials running where you are, and whether you think that will be something that changes in the future as well.
Okay. Thank you for this great question. So yes, COVID post-COVID, there would be changes in the clinical trials inevitably. We would not have a control for this. There would be good things, there would be bad things. So, so it has affected clinical trials and the research in Pakistan. There were good things we have learned. There were bad things. The trials were halted. There were suspensions. There were recruitment problems. And then, so these were the immediate effects. There would be long-term effects as well. There are a few good things that we have learned. So it has been discussed already in the forum, in the webinar, that clinical trials site, they came together. We were able to work in coordination. But previously in Pakistan, we do not have active research groups, or we can say in Pakistan, the researchers were not collaborating to the extent that they could have. So this had a bad impact. Pakistan was not able to showcase their full potential. Rather, we were able to showcase ourselves as small groups or single site or a group of limited number of sites. So, but with COVID, we were able to come up, we were able to work in collaboration, we were able to work in a synchronized way. And the good thing was that the National Level Ethics Committee as well as the Drug Regulatory Authority, they also acted fast and adapted, and this was a positive effect. So these are the positive things that we believe would have a long-term effect on research in Pakistan. The image of the regulatory bodies, it has changed, especially to the healthcare workers. We were, it seems to us that the Drug Regulatory Authority and the Ethics Review Board, they have acted fast, they have done positive changes. They are now working in a more synchronized way. We were not a very mature regulatory system. We were more decentralized. So, but with this, at least we have started a dialogue. We have come together. So how I see this, we need to keep this dialogue alive. We need to take it up, and we need to build our capacity for, and to fill in the gaps which were there, which we were able to fix during this COVID-19 in the pressure to act fast. But we need to continue to work in a more synchronized way, in a more efficient way, and in a more collaborative way. So this is the good thing, and this would essentially have a positive effect in research and clinical trials in Pakistan. Yes, thank you. I hope this answers the question.
Absolutely, yes. I think the collaboration, and also interesting to hear about the changes with the regulatory authorities and the ethics being very reactive. That's definitely a positive outcome, that's quicker. What sort of trials are you conducting? Are you mainly academic, or do you have interest from the big kind of clinical trials, the commercial trials? And is that something that moving forward you would like to have more oncology commercial trials? That was a question from one of our members earlier.
Right. So Pakistan has the potential to do clinical trial, but we are not doing clinical trials to the full capacity. There have been reasons. There are reasons internal to Pakistan. There are international factors which are playing a part. So we do have, we are sixth biggest population in the world. We do have a big population of treatment-naive patients. We do have capacity. We do have many sites. We do have a pool of physician investigators who have experience in clinical trials. But Pakistan is not a country where we do have many clinical trials. In recent years, there has been changes in the number of clinical trials that we are doing. To start with, there were many industry clinical trials, and then we have witnessed many academic clinical trials coming to Pakistan. But it's our feeling, or it's our there are facts, there are reasons to believe that we can participate even in more clinical trials. But there were internal factors, as I mentioned earlier, the lack of the groups, or the lack to showcase the potential in a way to attract international collaborators, as well as to lobby with the local government to support us in doing clinical trials. These have impacted us in a negative way. So we were not doing as many clinical trials we would love to do. So at the moment, if I would say, there are industry clinical trials, there are academic clinical trials. If I talk about my center, we do have a bigger number of academic clinical trials right now. We see the pharmaceutical company, maybe there are hindrances for them to come to Pakistan. One reason could be we do not have the policies to attract them, or the local pharma company or the pharma industry is not they cannot keep a pace with the international R&D sector of the pharma company. So that could be one reason. So academic clinical trials, at the moment, the number is high for academic clinical trials. In our center, we are doing a lot of investigator-initiated trials. But these investigator-initiated trials, of course, these have limited scope because we do not have great funding opportunities. So there is an interest, there are expertise, there is some capacity. But the clinical trials which are investigator-initiated, these are small clinical trials, mostly single-center clinical trials. So, but the number is huge. So I hope this answers your question.
Thank you. It sounds like definitely there's capacity to increase in the future. I'm just wondering, does anyone else have any particular points, closing points that they particularly want to make that we think we've not covered? I mean, we've covered a very broad remit, but maybe if there's any final points that anyone wants to say, maybe Alyssa, is there anything else that you'd like to add to what's been said already? And then we'll just go through everyone briefly with closing remarks.
I think
sorry to put you on the spot.
No, a lot of good points have already been made, and I certainly think the focus again on patients and physicians and their need to find ways of coping with what's happening right now is very critical. But looking ahead, looking to long-term potential implications, what can we learn from technology applications, from data? There's been a lot of discussion on the call and more broadly about the greater collection and sharing of information, and with that you get into again issues of data capture, data privacy, data access, and the responsibilities around that. There could be incredible benefit for the research community, for patients, but one needs to be cautious in how patient data is cared for. So those are areas that I think we're now seeing are going to be very, very beneficial in the clinical trial space. We already know that, but even more so. And there needs to be greater attention to how that data can be used. We talked a bit about health system design and how patients can be included in a way that's safe for them, which I think, again, is a longer term issue that a lot of careful thought needs to be put into. We talked about how technology may be able to affect trials and trial design. There's been a lot of questions, especially in the oncology space, how can trial design be potentially modernized? And I think now we're potentially going to find ourselves being faced with questions around how data can be used, applied, getting into adaptive trials, seamless trials, and the role that then AI and machine learning takes in those spaces. So I think from all of that, there are opportunities to apply technologies to answer questions that existed around clinical trials before COVID, but have really been brought to the forefront because of COVID, and really forced people's hands in trying out these new technologies and coping with how they impact clinical trial research. Additionally, I just want to circle back to talking about diversity in clinical trials, access to clinical trials. We've long known there have been disparities in healthcare and issues with access and system inadequacies, and COVID has really, really brought those to the fore. And this again is something that I hope the global community really seeks to address as we start to move into the next phase of this COVID era. Thank you.
Thank you so much, and thank you for the fascinating insights that you've provided today about the interaction between people and how we can usefully employ technology. That was so interesting. And Mariam, have you got any final comments you would like to share just as we're closing now?
Thank you. Just, I think, two final related points. I think this pandemic has also highlighted the issue of the pandemic of misinformation and how research can help address that. And I think what we have learned is that the role of community engagement while we do research is just as crucial if we are to ensure that there is better trust in the community for the suggested containment measures. And one of the areas that is crucial to achieve this is to integrate the social sciences model of research with the biomedical model of research. Because unless we understand community behaviors, we won't be able to really use the biomedical interventions that we are discovering for cancer patients or for any COVID-19 containment.
Thank you so much. And finally, Igor, I think we have about 1 minute till we close. Have you got any final exiting remarks or last comments?
I'm gratitude for this opportunity to talk with all this team. And I'd like to say, I absolutely believe that due to COVID infection, we will have very good results finally. And we will obligatory improve our management process, the management principles. We have to improve ourselves. We must become better, more powerful, more strong. We must survive and win this very hard struggle. And we will do that. I absolutely believe, and I think that if we will do it together, we will win. We will be the champions. Thank you for all of you for this nice evening. Thank you.